All right, so today we'll move on to small airway disease, and mostly we'll talk about bronchiolitis. So the definition of bronchioles, so these are the small airways without cartilage within the wall. So they're usually less than 1 millimeter in diameter. So as we go down the airways, we get the segmental bronchi, subsegmental bronchi, and then we get to the bronchioles. So these are non-cartilaginous airways. The membranous bronchioles are purely conducting, so they don't have any alveolar air sacs within the walls, as opposed to the respiratory bronchioles, and the respiratory bronchioles contain alveoli in the walls. And the sites of gas exchange, of course, occur where the alveoli are, and then these will eventually lead to the alveolar ducts and the alveolar sacs. So we're talking about disease that affects very small airways here. So the membranous bronchioles, purely conducting, the respiratory bronchioles, they're way down here. These contain alveoli in the wall. So here you're looking at a secondary pulmonary lobule, okay? And so here's a respiratory bronchiole going into it, and then you can see there are alveoli within the walls there until you get to the air sacs there, terminally. So bronchiolitis involves inflammation of these bronchioles, so we'll talk about that. So bronchioles are located at the center of the secondary pulmonary lobule. So the secondary pulmonary lobule is outlined by these interlobular septae. And then right in the middle, we have the central lobular bronchiole. These bronchiolar walls are very thin. They're less than 0.1 millimeter in thickness. So normally, the bronchiolar walls are not visualized on high-res CT. So the central lobular bronchiole, normally we don't see it on high-res CT unless there is some disease. The central lobular artery, though, you could see that's also in the center of the secondary pulmonary lobule that we will see on CT because all of this is vascular, so you'll see that. Bronchiolitis is divided into, when we're talking about the CT appearance of these diseases, there are direct signs on high-resolution CT of bronchiolar disease, and then there are indirect signs. The only indirect sign is really air trapping. But these direct signs, branching or Y-shaped linear density, so we're familiar with that as tree and bud, and that occurs because the bronchiole is filled with infected secretions, and it dilates, but the secretions themselves add to the density of the bronchiole, so that's why we see the tree and bud. We can have poorly defined central lobular nodules on CT, and that occurs because of inflammation around the bronchioles. And then bronchial wall thickening, this is less common. You might see a central lobular lucency if the bronchial wall itself is thickened enough from disease that it shows up, but that's pretty rare. We usually don't see that. So when we talk about what diseases can cause this, tree and bud, we think of infectious bronchiolitis. So tuberculosis, atypical mycobacteria, any kind of infection can give you bronchiolitis in tree and bud opacities. Poorly defined central lobular nodules without tree and bud. So especially if you have ground glass, central lobular ground glass opacities, we think about inflammation around the central lobular bronchioles. So respiratory bronchiolitis, which we've covered, subacute hypersensitive pneumonitis, or just the appearance of hypersensitivity pneumonitis before you get fibrosis can have that appearance. And then air trapping, this can occur whenever you have bronchiolar disease, but if air trapping is the only abnormality that you have, in addition to other small airway diseases, one disease that we will consider is constrictive bronchiolitis, where there is scarring essentially around the central lobular bronchioles, and that results in air trapping, and that's the only manifestation of disease that we see on CT. So tree and bud is pretty easy to understand. You have infected secretions here within the bronchioles, and that will cause them to be increased in opacity, and because the ends kind of dilate a little bit and fill with these infected secretions, you get these tree and bud opacities on your CT scan. So we should be seeing this fairly soon, tree and bud in the springtime, right? And then that's what these infection or bronchiolitis gives you on high-res CT. Normally, as we've said, the bronchiolar walls are very thin, so we usually don't see them either when they fall within the plane of the slice or when we cut them in cross-section. Because those walls are so thin, we usually don't see these normal terminal bronchioles. So we're all familiar with what tree and bud looks like. So we have these little nodular opacities. They're central lobular in distribution, and they're kind of branching. And so whenever we see tree and bud opacities, then we think of bronchiolitis. So that inflammation affecting the inside of these bronchioles. So what can do that? Aspiration is something, especially if it's in the dependent regions of the lower lobes. So that's something that's pretty common. So that is something that you should consider. And then we have any kind of infection, endobronchial spread of tuberculosis, atypical mycobacterial infections, patients who have underlying diseases that will result in recurrent infections like cystic fibrosis or immunodeficiencies. So that can also result in recurrent infectious bronchiolitis. So here's an example of somebody with cystic fibrosis, and you can see these nice tree and bud opacities representing bronchiolitis. And then another example here. Also, another sign that you have airway disease is if you can see these smaller subsegmental airways, when you can see thickening of the walls of those airways. So that also tells you that you're dealing with airway disease. So if you're wondering sometimes if you see these small nodules, is it a manifestation of airway disease? Look for other evidence of airway disease. Look for bronchial wall thickening. So if I tell you that this patient has recurrent Pseudomonas and this patient is from Japan, there is a rare disease that gives you recurrent infectious bronchiolitis, especially Pseudomonas infections in Japan. What is that?
Diffuse panbronchiolitis.
Yeah, so Asian panbronchiolitis, okay. If I didn't tell you the person was from Japan, but they had Pseudomonas infections and bronchiolitis, you might think of, especially in a younger person, you would think of what? Cystic fibrosis, right. But this is an example of Asian panbronchiolitis, or also called diffuse bronchiolitis. So unknown etiology occurs in Asia, especially Japan and Korea, tends to affect male patients. They may also have sinusitis, and they will have inflammation of their bronchioles and recurrent Pseudomonas infections. You might see nodules on the chest radiograph. On CT, we'll see the tree and bud pattern, predominantly at the lung bases, dilated, thick-walled central lobular bronchioles. They might have bronchiectasis. They can also have air trapping, so that can increase the lung volumes. So you might have increased lung volumes from air trapping, since ill-defined nodular opacities, predominantly at the lung bases, like you see there. But on the CT, we can see that there's evidence of airway disease, there's bronchial thickening, and then we have these tree and bud opacities. So when we see that, we think of inflammation involving the bronchioles and bronchiolitis. It's just a matter of what is causing this. Another example with a little bit more bronchiectasis and parabronchial thickening in this particular patient. Okay. So you should be familiar with this appearance. What do we have here on the CT in this case?
Looks like there's mosaic attenuation.
There's mosaic attenuation. What else do we have? Well, the topic of the lecture is bronchiolitis. What evidence do you have that there's bronchiolitis?
Is there air trapping?
There is air trapping, right? That's the mosaic attenuation, but does the lung parenchyma itself look normal?
No.
What's wrong with it?
It's like diffuse tree and bud.
Well, so you see all these guys, right?
Are those all central lobular, actually?
Well, you tell me. Are
Yes,
these central lobular? How do you know they're central lobular?
They don't really contact the pleura.
Right. They're not in contact with the pleural surface. Important finding. What's the attenuation?
Ground glass.
Ground glass,
Yeah.
right? So whenever you have ground glass nodules, it's pretty much always in what distribution?
Central lobular.
Central lobular. Ground glass nodules are pretty much always in a central lobular distribution. Right? So you have ground glass nodules in a central lobular distribution, and you said that you have mosaic attenuation from
Air trapping.
air trapping, right? How do you know it's air trapping?
That's a good question. Well, looking at for like vascular abnormalities and.
Well, one helpful clue is when you look at the vascularity in this region, right, in this region of lucency.
Looks
that-
within normal limits. I mean, for.
Well, is the vascularity here normal, or is it less than it should be?
Less.
Yeah, it's actually less than it should be, right? So there are less vessels there, okay? Secondly, another important clue that tells you that this is air trapping is that these areas of lucency break down into what? Well, that shape should be very familiar to you. What's that shape? This is the shape of a secondary pulmonary lobule. So it breaks down into secondary pulmonary lobules, and that's also typical of air trapping. So what's this person's underlying disease?
Hypersensitivity.
Hypersensitivity pneumonitis, right. So we have central lobular ground glass nodules, and we have air trapping, right? So this is somebody with hypersensitivity pneumonitis, right? So we've covered this before. Poorly defined central lobular nodules, no tree and bud. We'll see that with hypersensitivity pneumonitis. We've covered another disease that can also give you central lobular ground glass nodules, respiratory bronchiolitis. Occasionally, infections can also give you central lobular ground glass nodules, but that might also occur. But always think about this, hypersensitivity pneumonitis, when you see central lobular ground glass nodules. And then there's some less common causes, although here the nodules are usually not ground glass in these cases. These first two are the most common causes of ground glass attenuation, central lobular nodules. And we also covered respiratory bronchiolitis. This occurs in patients who are smokers, and so this also results in inflammation around the central lobular bronchioles. And if they are symptomatic, then it's called respiratory bronchiolitis associated interstitial lung disease. And that would also give you central lobular ground glass nodules. So with that disease, it does respond to steroids, and if the patient stops smoking, so you have central lobular ground glass nodules, and it gets better if the patient is treated with steroids and if the patient stops smoking. Just when you think you understand all this stuff, you might come across a case like this. So the finding here is
Diffuse a particular nodular.
well, which is it? Is it mostly nodular, reticular?
I'm going to go with.
I mean, reticular nodular is not a bad description. I think that's right. But there are lots of these, these small nodules here. Okay.
Yeah.
All right. So here is the CT, and the CT also shows what? So again, you have these small nodules, and what pattern do we see with these nodules? What would you say?
Bronchovascular.
Yeah, sort of. Yeah, I would agree with that. But do these look tree and bud?
Yeah.
Yeah, they do look tree and bud, right? They're not really touching the pleural surface. They kind of look like tree and bud nodules. So as we've said, when we see tree and bud nodules, we think of what? We think of bronchiolitis, right? You think of disease involving the airways and bronchiolitis, right? So here's a coronal reformat of that, right? Much better. Now you're convinced that it's what? Tree and bud, right? Now you're absolutely convinced this has to be tree and bud, right? So you're thinking of what kind of disease?
Could be like, could be even TB, atypical.
Yeah, sure. TB,
bacterial.
bronchiolitis, infections, right? Any of that stuff could do it. I want you to look at this and tell me what's kind of peculiar here.
Almost looks like it's following the vasculature.
Yeah, all of these nodules are connecting with the vessels. Can you appreciate that?
Yeah.
Yeah.
It's like an anterior.
Right? So what does that mean? Is this airway disease?
No.
No. What is it? So This is a rare cause of a tree and bud pattern, right? So we think of tree and bud as being airway. We see tree and bud are reflexes, that's airway disease. But here, you also have kind of a tree and bud pattern, but these all connect to the vessels. So remember the vessels, the central lobular arteriole, right? The vessels also go to the center of the pulmonary lobule and they can be branching, right? So here we have some kind of vascular problem that is giving us all of these tree and bud opacities, right? Any idea what this could be?
Pulmonary hypertension.
What?
Pulmonary hypertension.
No, pulmonary hypertension doesn't do this, right? So what does pulmonary hypertension do to the blood vessels? You should see what?
Central. You see like what central?
Well, you should see enlargement of central pulmonary arteries. Although this disease is also associated with enlargement of central pulmonary arteries, right? But pulmonary hypertension, especially in the later stages, gives you pruning of the distal vessels, right? So the vessels are enlarged centrally, but distally they're not as prominent.
Could it be like microembolic?
Yeah, so this is microembolic disease, right? And so the term for this, or how does this occur? What happens here? How does this happen? So these represent microemboli. When it's diffuse like this all over the lung, it means what? It means the patient's injecting something, right? And now the small particulate matter that is embolized to all of the distal small vessels within the lung. So this is called excipient lung disease, IV talcosis, cellulose granulomatosis. It's from IV abuse of oral medications. So what happens is they take the oral medications, they ground it up, and then they inject themselves with it. The problem is that the pills contain binding agents like talc, cellulose, and starch because they're meant to be ingested. They're not meant to be injected, right? And so those binding agents is what winds up embolizing to all of the small vessels within the lungs. And so that then gives you this pattern, this pattern of multiple microemboli, and essentially it looks like tree and bud, but it's very diffuse. And all of these are connected to the blood vessels. You might see this in a more limited fashion. If this is more limited in terms of distribution, this can also occur from what? When it's diffuse like this all over the lung, you think injection. Patients injected something. But if it's more limited in distribution, not septic emboli, but tumor microemboli, right? So very rarely tumor microemboli might give you a similar appearance, although it tends to be later in the stage of the tumor, so it's well known that the patient has an underlying malignancy, right? But that also might give you this. So a rare cause then, vascular disease, microemboli is a rare cause of a tree and bud pattern. And if it's diffuse all over the lung, you think of injection, excipient lung disease. If it's very localized, then you think of tumor microemboli. But again, with the tumor microemboli, it's not a mystery. It's usually known that the patient has an underlying tumor. All right, so let's move on to indirect signs on high-res CT of bronchiolar disease, air trapping. So the air trapping is best seen on expiratory views. Here's a patient with diffuse bronchiolitis. Here's a patient with sarcoid. Here's a patient with chronic hypersensitivity pneumonitis. And you can see the air trapping diffusely. It turns out that just about any disease that affects the lung diffusely can give you air trapping, can affect the airways. So whether it's sarcoid or some other diseases, if it affects the lung diffusely and severely enough, you can get air trapping as a manifestation, but that won't be the only manifestation of that particular disease. There'll be other findings that would go along with that disease. So that's the first thing to realize. We want to concentrate on what if air trapping is the only finding. So air trapping is best seen on expiratory views. You might see some mosaic attenuation on your inspiratory views, but that can be very subtle. But the expiratory views are very helpful to showing you those areas of air trapping. And again, the air trapping breaks down, if it's true air trapping, it can break down into these secondary pulmonary lobules, which tells you then that this this mosaic attenuation, what you're looking at is you're looking at air trapping, okay? So air trapping causes, why does this happen? Air trapping causes hypoxic vasoconstriction, so the blood is shunted away from the regions of air trapping to areas of normal lung, which is why the vessels also are somewhat more prominent in these areas of more normal lung. This looks like ground glass opacity. So many times you're looking at this trying to decide, well, is this the abnormal lung or is this the abnormal lung, because this looks like ground glass. But if you look at the blood vessels, you'll notice that the blood vessels, the distribution is more normal in these areas, and there are less blood vessels in the areas of lower attenuation. So that's telling you that the blood has been shunted away from these areas, and that contributes to the increased attenuation of these areas, giving you that ground glass appearance. Okay, so that helps to tell you which parts of the lung are abnormal, looking at the blood vessels. So asthma, this is a very common disease. If you happen to do expiratory views in somebody with asthma, you will see air trapping. So small airway diseases can give you air trapping and mosaic attenuation. Chronic bronchitis, very common disease. If you happen to do expiratory views in a patient with chronic bronchitis, again, you can see areas of air trapping, not unusual. So if air trapping is the primary abnormality, we're thinking about small airway diseases, okay? If I tell you, though, this patient has a history of bone marrow transplant, first of all, what's different between the inspiratory and the expiratory view?
Mosaic attenuation.
Yeah, there's mosaic attenuation. Why? There is?
Well, there's air trapping.
There's air trapping, right. And again, you look at the blood vessels here, ground glass here, but these areas are more lucent, the blood vessels are smaller. That tells you that these are areas of air trapping. So given this history, what's wrong? What does this patient have?
Bronchiolitis obliterans.
Yeah, so constrictive bronchiolitis or bronchiolitis obliterans, right? The manifestation of that air trapping might be the only manifestation of that on your CT scan. Given that story, what's the cause of the bronchiolitis obliterans?
Graft versus host disease?
Yeah, so this is graft versus host disease. So after bone marrow transplant, the bone marrow can attack the native lung. And when it attacks the native lung, it attacks the small airways, causing constrictive bronchiolitis, which then can manifest as air trapping. There's another type of transplant that can also manifest as constrictive bronchiolitis. What transplant is that?
Lung transplant?
Lung transplant. So the manifestation of rejection of lung transplant is also as constrictive bronchiolitis. That's why those patients are followed with pulmonary function tests to see if they're developing obstructive physiology. So what is constrictive bronchiolitis? This is what a normal bronchiole looks like. When there's bronchiolitis obliterans, we get concentric fibrosis here, these fibroblasts around the airway. You can see how they narrow the airway, and this is what's going to manifest as air trapping in these patients. So do not confuse this with BOOP. This is one of the regions that terminology was changed, bronchiolitis obliterans with organizing pneumonia. With BOOP, the primary problem is in the air spaces, the organizing pneumonia. And then secondarily, that fibrotic process, then you get these fibrinoid plugs that invade the small airways. That's causing the bronchiolitis obliterans. Here with bronchiolitis obliterans, the fibrotic process occurs directly around the small airways. It does not involve the alveolar air spaces. All right, so there's a difference between BOOP and bronchiolitis obliterans, even though the terminology might be confusing. So what are causes? Well, it can be from transplant. Lung transplant, rejection of a lung transplant, there's bronchiolitis obliterans. Bone marrow transplant, the transplanted bone marrow can attack the native lung. That's called graft versus host disease. Swyer-James syndrome is post-viral bronchiolitis obliterans, so that could also cause constrictive bronchiolitis. Inhalation of noxious fumes, Silo-Filler's disease, smoke inhalation, that can also, as a sequela, those patients can also develop bronchiolitis obliterans. Can be related to connective tissue disorders like rheumatoid arthritis, penicillamine as a drug, and then there are some rarer causes of bronchiolitis obliterans. So after transplant, it can occur after lung transplant, or or after bone marrow transplant. But after lung transplant, about 50% of patients can develop constrictive bronchiolitis within 6 months to a year as a manifestation of rejection. So they'll develop progressive shortness of breath from obstruction of the small airways. So that's why they're followed with pulmonary function tests to determine if they're developing obstructive physiology. After bone marrow transplant, 2 to 13% of patients can also develop constrictive bronchiolitis. That is graft versus host disease. That can occur any time greater than 3 months after bone marrow transplant. So usually the chest x-ray is normal in these patients. It might show hyperinflation from air trapping, but many times it's normal. What do we look for on CT? Mosaic attenuation, air trapping, what looks like ground glass, but these are really areas of more normal lung. The blood flow has been shunted away from these areas of air trapping. So it's important if you get the history of that they want to rule out bronchiolitis obliterans and you're doing a CT scan for that, what should you do?
Expiratory abuse. Expiratory abuse.
Yeah, so you want to do inspiratory and expiratory abuse, right? Because you're looking for the air trapping, right? And the best way to see that is on your expiratory abuse. So it's important to exclude expiratory abuse in your protocol if you're looking for small airway disease or bronchiolitis obliterans. Right? Mosaic attenuation, it can be subtle if you're only looking at inspiratory abuse, right? So we're familiar with what that looks like. You might also have mild bronchiectasis in patients with bronchiolitis obliterans. They might have mild bronchiectasis. So we'll see mosaic attenuation and mosaic perfusion. You might have some mild bronchial dilatation in the lower lobes. Look for air trapping, mosaic attenuation, right? We've talked about that. The most specific signs for bronchiolitis obliterans are bronchial dilatation in the lower lobes and air trapping. So on inspiratory views, you might see some mosaic attenuation, but on expiration, you'll manifest the air trapping much better. So look for that. You might have some parabronchial thickening, right? So that you might also see in cases of bronchiolitis obliterans. Some other rarer causes of bronchiolitis obliterans, this is called flavor worker's lung. So this is bronchiolitis obliterans from exposure to diacetyl butadiol. I don't know if I pronounced that right, but it's a ketone used for butter flavoring of microwave popcorn. So there was instances of people working in these factories who were developing this mysterious lung disease, and this is what it turned out to be, called flavor workers lung bronchiolitis obliterans from exposure to that. What do we have on this chest radiograph?
The vasculature is more prominent.
Where?
On the right side.
Yeah, so the vasculature on the right is somewhat more prominent, true. You notice anything else?
Like the left lung is like more loosened.
What about the right heartboard? Where's the right heartboard?
Oh, there's some mediastinal shift
Towards
towards the left.
side, right? And the vascularity in the left lung is diminished, right? So there's some shift of the mediastinum towards the left, and the vascularity in the left lung is diminished. How do you put that together? Well, what do we see on the CT?
Wedge-shaped on the right lung, primarily wedge-shaped, I don't want to say mosaic attenuation, but like ground glass attenuating lung.
Well, again, if we look at the blood vessels in these more loosened areas, right, the blood vessels are diminished, right, in those loosened areas. Now, you said that the left lung had diminished vascularity, and you said the size of the left lung was, what did you say? Yeah. So you actually used the word more lucid. So you put all that together, what do you get? Smaller lung that's more lucid is what? What's the underlying disease? Small hyperlucent lung, what is that?
Squire James.
That's Swire James. Okay. See how easy it is? So this is a patient, as it turns out, with Swire James syndrome. Bronchiolitis obliterans as a child. Actually, it's a young patient. He's a teenager. So Swire James syndrome, post-infectious bronchiolitis obliterans, usually sequelae of adenovirus infection in childhood. So that causes constrictive bronchiolitis. It is a bilateral disease, but one lung might be affected more severely. It doesn't grow as much, so that becomes the smaller, more hyperlucent lung. But as you can see, it is bilateral disease. It does affect both lungs. Okay, so that's Swire James syndrome. What about this case? Do we have mosaic attenuation?
Yes.
Yes, we do. So, are you suspecting small airway disease here, or are you suspecting something else?
Central vasculature looks prominent.
So, these vessels look pretty big, right? So let me show you some more images with contrast.
Chronic.
Yeah, so this is chronic thromboembolic disease. So you can see the finding of chronic thromboembolic disease is what? How do you know?
Enlarged pulmonary trunk. There's filling defect.
What about the filling?
Peripheral.
There.
All right, so here, there's eccentric filling defect. What do you see on the right side?
It's also eccentric.
Well, there's something else very nicely demonstrated in that right side. What is it?
Oh, it's so dilated.
What is this?
Oh,
See that?
it's like
What is that?
Like curvilinear, actually.
Yeah, so what is that?
So, oh, I know what you're talking about. It's like a film. It's a
What's it called?
webbing.
That's a web, all right? So that's sign of incompletely recanalized thrombus, right? So that is a web. This patient also has a complication of their chronic thromboembolic disease. What complication is that?
Pulmonary hypertension.
Yes, it's pulmonary hypertension. How do you know?
Pulmonary trunk is dilated.
Well, how else do you know?
Look at the right ventricle.
What about it?
It's dilated relative to the left.
Yeah, so the right ventricle is dilated. You can see it's pushing on the interventricular septum, right? And what else do you notice about the right ventricle? It's hypertrophy. Look at the muscle here, right? So you have a dilated hypertrophied right ventricle. You have a dilated pulmonary artery. You have these eccentric filling defects here within the pulmonary vessels. Here's a web. This is chronic thromboembolic disease, and this patient has pulmonary hypertension as a result of the chronic thromboembolic disease. So here's the web on this side, okay? Here's eccentric filling defect on that side. Here's the web again on this coronal reconstruction, okay? Here's another somewhat more dramatic example, mosaic attenuation, and we can see that these are clots, these are eccentric thrombi here and also here. So another example of chronic thromboembolic disease. And so here what we're looking at is not really air trapping, but we're looking at a difference in perfusion because of obstruction of the smaller vessels. So this chronic thromboembolic disease not only affects the big vessels here, but also will extend to the smaller vessels distally in the lung. And that will give you these differences in perfusion. And that can also give you this appearance of mosaic attenuation and actually mosaic perfusion. Again, notice that the vessels in these areas are not as prominent as the vessels in the areas that look like ground glass, right? So when we talk about mosaic attenuation, the term mosaic attenuation, that term is a non-specific term. It means that there's differences in attenuation between different areas of the lung. So you'll have areas of increased opacity, areas of decreased opacity, usually, ground glass and more lucid areas. The term mosaic perfusion is a more specific term. That means the blood vessels are decreased in size and number in the lucent areas because the blood flow has been diverted to the areas of normal lung. Right? So we can see that with air trapping, or we can see that with vascular disease, commonly chronic thromboembolic disease. If it's air trapping, then you would expect on your expiratory CT that the lucent areas of lung would be more prominent on expiratory CT, and that can help you to differentiate air trapping from underlying vascular disease. So infiltrative disease can give you mosaic attenuation. You'll have ground glass interposed with areas of normal lung. Small airway disease can also give you mosaic perfusion, but vascular disease like chronic thromboembolic disease can also give you mosaic perfusion, and here it's the air trapping that causes the diversion of blood flow away from those areas where there's air trapping. Here it's actual vascular occlusion that causes the mosaic perfusion. So infiltrative disease can give you mosaic attenuation. This is a patient with pneumocystis, ground glass, and then you have these other areas of the lung that look more lucid. But here the ground glass is the abnormal area. If we have mosaic attenuation from small airway disease, the ground glass areas are the areas of normal lung. So the abnormal lung are the areas of lucent lung, and then what helps is to look at the difference in the blood vessels between these areas, and that helps you to decide what's the normal lung and what is the abnormal lung. And similarly, you might see something like that with chronic PE, chronic thromboembolic disease, vascular disease, that will also give you these areas of mosaic perfusion, with the areas of lucent lung having decreased size of the blood vessels. So how do you tell them apart? How do you tell if you have mosaic perfusion, how do you tell if it's vascular versus airway disease? Well, one thing that could help is, you look for signs of chronic thromboembolic disease, look at your blood vessels, is there evidence of chronic PE? But there is a difference in the pattern that you can appreciate between vascular disease and air trapping. And what's the difference in the pattern that you can appreciate?
I feel like secondary pulmonary lobules.
Yeah. So when you have air trapping, it breaks down into these secondary pulmonary lobules. Whereas if you have vascular disease, it's somewhat more diffuse, usually more in the periphery of the lungs. So that can really help. So vascular disease gives you these larger areas of lucency, more peripherally distributed. If it's airway disease, it's smaller, these areas of lucency, and they will break down into regions of secondary pulmonary lobules. So if you look for that, that can help you differentiate between vascular disease and small airway disease. So small airway disease, look for secondary pulmonary lobules, like you see, and expiratory imaging can help, right? How do you know that's an expiratory view?
The trachea.
Yeah, so you look at the trachea. The posterior wall of the trachea bows forward. So that can also help if you see air trapping on a CT scan for PE. You wonder, gee, was this an expiratory view? Look at the trachea. You can see that the posterior wall is bowed forward. That's an expiratory view, and you can see the air trapping much better on that expiratory view. If we have vascular disease like chronic thromboembolic disease, especially with patients with pulmonary hypertension, in addition to looking at the abnormalities within the blood vessels, just the pattern of the mosaic perfusion in the lungs, you see that the lucent areas tend to be more peripherally distributed and somewhat larger, and really don't break down into secondary pulmonary lobules. Okay. So infiltrative disease should not give you air trapping, should not give you mosaic perfusion. Small airway disease will give you mosaic perfusion and will give you air trapping. Vascular disease will give you mosaic perfusion but should not give you air trapping. We've talked about the difference in the patterns of these two, even though both of them will give you mosaic perfusion. So if you look at the size, if you have mosaic attenuation, look at the size and number of the blood vessels throughout the lungs. If the size is the same in the areas of ground glass and the areas of lucent lung, think of infiltrative disease giving you ground glass opacity, like pneumocystis, pulmonary edema, etc. If they are different, right, if the areas of lucency have smaller blood vessels, now we have mosaic perfusion. If you happen to do expiratory CT and you see air trapping, then you know it's airway disease. We've also talked about, though, we look at the pattern, right? If it breaks down into secondary pulmonary lobules, then you're probably dealing with airway disease and air trapping rather than vascular disease. Some caveats about air trapping. Air trapping is not helpful as an isolated finding, especially if you're not looking for it, okay? What I mean is they're not sending you a patient that you're imaging looking for small airway disease. You happen to be doing a CT for PE or CT for another reason, and you see air trapping. And it's very common to see, and the significance of this can be uncertain. We can see air trapping in normal patients. You can see air trapping sometimes even in patients with infiltrative disease, and in some cases even with vascular disease, you might see air trapping. Air trapping with bronchial dilatation can be specific for small airway disease like bronchiolitis obliterans. And there are cases of vascular disease, even chronic PE, that might show you areas of air trapping. So in real life, this is a little bit more complicated than the textbooks would, want you to believe. So here's a patient with chronic PE who does demonstrate air trapping on expiratory views. Okay. This is a normal patient. Normal patients can also demonstrate air trapping if you happen to do expiratory views on those patients. So 38% of non-smokers with normal pulmonary function tests in this study demonstrated significant air trapping. Some air trapping there in a perfectly normal patient. Okay. Here's some extensive air trapping in an otherwise normal patient. Okay. So just because you see air trapping on a CT does not necessarily mean that that is clinically significant. So you have to be careful of that. The party line for examinations. On exams, if you see significant air trapping, especially on expiratory CT, consider it abnormal. Think about small airway disease, COPD, asthma, bronchiolitis obliterans. If that is the only abnormality is air trapping, your primary differential will be small airway disease. The problem in real life is our CT scanners are very sensitive to air trapping, so it's easily demonstrated even in normal patients. So if we come across air trapping in normal patients, how significant is it? We're not sure. So you need to correlate with symptoms. Were they sending you to patient because they were looking for small airway disease? Is the patient short of breath? Does the patient have obstructive physiology on pulmonary function test? And you'll see sometimes when we read these cases, if we see that there's significant air trapping, we will say it could be secondary to small airway disease, recommend correlation with pulmonary function tests. Okay, so you can use that. All right. All right, so that is our discussion. Any questions? All right, so we'll have a quiz next time.